Okay. Tonight, Ravi is going to talk to us about measuring health from tools to data to value. So, without further ado, let's start the talk, and I will turn it over to Ravi.
Okay. Thank you everyone for joining. I know it's the end of summer semester, at least for those of us who are still in school. And I appreciate you taking the time off on the evening. So just some brief background. I'm an assistant professor at UMass Amherst. I just started this past fall. Before that, I received my PhD from University of Washington. Um, So just to get things started, I wanted to do a show of hands of like how many people do some tracking of any aspect of their health. This can be either using a device, an app, or even manually. You can either use some emotes or type in chat or just speak out loud. Okay, great. I can also see some people. Okay, perfect. So at least a few of us, right? The reason I asked this question is like much of my research is around sort of tracking and measuring health. So just want to get a sense of like how if people actually have some personal experience doing that, or if people are just coming in new here. So with that said, let's do some audience participation to get things started. I pasted this link in chat. You're also welcome to just type it in. This is a Padlet. So it's essentially a sort of think of it like a bulletin board where you can just write your comments. And I want to see what people's perspective or opinions are on three questions. The first one is, what does health mean for you? The second one is, what is the pinnacle of the current health technology in your opinion? And the third is, what is an underexplored area of health technology? And the responses are something that I want to sort of come back to near the end of the talk, where I want to have a more sort of open discussion around the future directions of this research. So I'll stop talking for a few minutes so people can fill it out. Perfect. Now let me start with the bulk of the talk. And I split the talk into two parts. The first part, which is going to be the majority of it, I'll be going over some of my past research projects in the area and just giving you a sense of where I'm coming from. And then for the last part, I'm trying to formulate some new line of thinking and research that I want to explore and just want to see how people react to that and how that aligns with the responses that I'm seeing here. So without further ado, broadly speaking, my research is at the intersection of human-computer interaction, computer science and engineering, and health and medicine. And as you can imagine, this is a pretty broad area, right? You can do a lot of different things in this. So specifically what I do here is I build tools which specifically I focus on combining human-centered design and data-driven approaches to build tools to support individualized health. And what I mean by this is I build tools which can be any combination of software or hardware that supports capture and interacting with some health signal that interacts with data, right? So, and by data, what I mean here is information about the particular signal about a person's health and well-being to provide a value. And what I mean by value here is it's either meeting the needs and expectations by providing new knowledge or insight to any stakeholder. So this can be the patient, this can be the caregiver, this can be the clinician, whoever it is. So this is the broad space in which I work. So essentially building tools to support new interactions with health data. And starting from the rightmost side, so starting from value, why am I talking about value? Value of health is highly personal. As you might have already seen in your responses to the first question, what does health mean to you? Different people have different interpretations of what health means to them, right? We also got a very first-hand experience with how people react to scientific literature in this space. When people say like masking up is proven to be really helpful in reducing the spread of COVID, then people come back to that like, that's just an average. I know people who haven't masked, who haven't gotten COVID at all. So easily knocked back by anecdotes, right? And people also are more focused about what's happening to them and what's happening in their own life. What matters to me is how the condition manifests in me. I don't know if the condition can have 10 different potential symptoms. I'm experiencing this one. What should I do here is my primary concern. And to meet this sort of different personalized values, how do we provide appropriate data for people to get this value, right? So as an individual, I might be highly vested in answering questions about myself, such as what is the potential trigger for my headache tonight? What is the likelihood that eating ice cream today is going to trigger my bloating tomorrow? For those of us who don't suffer from chronic headaches or irritable bowel syndrome, these may come across as trivial questions, right? What's the big deal? But for those who do experience these sort of conditions, it has a huge impact on the day-to-day quality of life. They really want these answers, and they really want tools which can support them in finding answers for this. So finally, how do we design tools that help them collect and interact with and use such data to get the meaning out of the things that they're experiencing, right? So in my work so far, I have primarily focused on chronic conditions. Chronic conditions are the leading cause of sickness, disability, and death worldwide. With an aging population, this is only going to get bigger and bigger in terms of its impact. Roughly 60% of the adults in the United States manage at least one chronic condition, accounting for as high as 90% of healthcare spending. And this ranges from heart diseases, cancers, lung disease, diabetes, migraines, you name it, right? And as technologists and human-computer interaction researchers, we have explored different ways of supporting these different populations. And through these efforts, we have come to realize the complexities that lie in this space. Sorry, Peter, you had a question. Please go ahead.
Yeah, I just noticed that all these conditions are physical illnesses, right? Is there also a space around chronic mental health conditions that is of interest?
Definitely. And that is something that I've explored in the recent past. And actually, I'm currently working with Alzheimer's and dementia population. So definitely something on my radar. It's just not something that I have results to show in this talk, but happy to have the conversation after if you are interested in that direction. So again, like these are just examples. Mental health also comes into picture here. And as we know, it's also a growing field of focus where more money is being poured in, and we are trying to figure out more technology interventions in that space. So it's definitely belongs here. I guess it's my omission here that might be off-putting to some people. So the primary complexity that I want to highlight are based on three sort of parameters or dimensions. One is many chronic conditions are highly individualized, where different people with the same condition have completely different interactions, reactions, and daily quality of life. So take the example of irritable bowel syndrome, where different people might have different reactions to different foods they eat. So no two people are alike with IBS at that point. And it becomes difficult to figure out like what's an appropriate technological intervention to support these different needs. People can also exhibit significant day-to-day and week-to-week variations, making it difficult to provide reliable feedback on how a person is doing without any objective measures. So migraines are really sort of a appropriate example in this space, where you never know when the next episode is coming, and you never know whether the potential interventions that you're trying are working out without having long-term data collection done on that. And finally, there's a significant impact on the day-to-day quality of life, where instead of just focusing on what's happening, a person has to be really mindful at all times about their choices, be it either in terms of mode of transportation, be it in what their diet is, or some other factor of their life. And to support individuals in this space, we first need to understand the current process of chronic care to better understand what the entry points are and where we can provide support. So this is one such model. I'm aware there are other detailed models in medical literature, such as the chronic care model. However, for the sake of simplicity, I'll just focus on this model when I talk about my projects. Usually a person shows up in a doctor's clinic when they have the initial symptoms. They do some diagnosis, they figure out some treatments. If the treatment is not working, they might redo the diagnosis. And basically, it's a cyclical process going on between diagnosis, treatment, and management, right? And this is also part of the triaging that someone mentioned in the underrated areas of health tech, underexplored areas of health tech in the response earlier. And there is a significant need of personalization of treatment and interventions in this space right now. So in my research, I've focused on the later three steps, so diagnosis, treatment, and management. And the bigger thing that I've tried to focus on is in many of these conditions, we know at a population level what the condition is, how to go about initially treating it, and how to support people. But when it comes at an individual level, we still don't have a good measure of figuring out like this is how the condition manifests in this person, or this is exactly what this person is experiencing, right? So we need a human-centered approach to design tools that create and leverage these new forms of data for individualized medicine. And the new forms of data are in the forms of like variables that we are using. We are doing genetic testing like anything. We have other signals which we were previously able to not capture at home. So we have all this data at hand, and now we are trying to figure out how to interpret that and use it to better personalize the support for these kind of conditions. So in my research, I designed, develop, and built tools to support people in collecting, interacting with, and using novel health data to improve personal well-being through personal insights and recommendations, right? So I leverage the human-centered design process to address the problems I'm solving, where I go through the typical design thinking approach of formative research, where I do the need finding, stakeholder interviews, and surveys and other approaches. Then there's the initial prototyping, feasibility evaluation, and then finally evaluating for even clinical use at that point. And like with any good HCI process, this is an iterative process, and you'll get a better sense of it when I talk about individual specific projects. And in building these tools, I draw upon existing theories in HCI of how people experience health-related self-tracking, right? So stage-based model of personal informatics might be something that people might be familiar with if they have sort of engaged with the personal informatics literature in HCI. It just shows the different stages at which a person thinks about tracking their health with respect to particularly with the end goal being behavior change, right? So if you're interested in changing your behavior, these are usually the steps that you follow, starting from preparation, collection, integration, reflection, and action. You have other models which built upon that, such as the model for lived informatics model for personal informatics, which takes into account like people stop tracking, they lapse, and then they resume again. How can we use this understanding to design better tools to support these processes? And then we specifically also have sense-making framework for chronic disease self-managed, where we are trying to understand who are the stakeholders, what are the different stages that are happening, and what are the actions that are happening in those processes, right? So in my research, I have broadly made two sorts of contribution. One is building novel tools. So like some of the tools that I'll be talking about today, stomach trials and Beacon. These are aimed at supporting people with irritable bowel syndrome and chronic liver diseases. I also worked with the migraine population on Migraine app. And in building these tools, I've also contributed back sort of design recommendations and frameworks, which other designers and researchers can use to better inform the design of their tools, right? So framework for self-experimentation, and then we argued for a Bayesian analytical approach and self-experimentation. And then we developed an instrument for evaluating early stage health technologies in terms of like, is it something that can be implemented clinically down the line? So figuring out how to gather early evidence. But for today's talk, I'll be just focusing on the top left corner. So the research question that I'm seeking to answer with the tools is, how do we design tools to support new experiences with personal health data, and thereby enabling people to better understand, participate, and manage their health and well-being? So with that, let's dive into the first tool, which is tummy trials. With this tool, it's a tool basically aimed at helping individuals in designing, executing, and analyzing self-experiments to identify specific food triggers for the symptoms. And in this project, we designed and developed a self-experimentation application for IBS patients. And we did the initial validation of the feasibility of the approach in terms of people being able to follow a self-experimentation approach in determining the triggers for their IBS. And this is roughly the structure of this section of the talk, where I'll first give you the context of IBS for those of you who might not be aware of what IBS is. What are the existing approaches that we have in that space in terms of how people are using technology, or even what's the current clinical gold standard approaches? What's the key research question that I'm addressing here, and then discussing the brief design and evaluation of the platform that we built. So IBS or irritable bowel syndrome is something that affects 15 to 20% of the US adult population. And it's characterized by episodic abdominal pain, diarrhea, constipation. And some estimates put the indirect cost of IBS as high as $10 billion. So it's a big impact that we're talking about. And the primary challenge with IBS lies in the sort of the spectrum of the ability, right? Where it is difficult for a person to figure out what their trigger for IBS symptoms is. Food is the most likely trigger for most people. So lactose, caffeine, and other common culprits. But for many people, stress is also a trigger for their IBS symptoms, or even sleep can be a trigger. So as you can imagine, like this answering just teasing about which one of this can be a potential trigger for you will take some time and effort. And if you don't have expert guidance, you will definitely, there's a high likelihood of you failing in this search, right? And the biggest issue is routine lab tests such as blood tests, x-rays, and endoscopies are often inconclusive. This is not an allergy, right? So you cannot just do an allergy test and figure out what your trigger is. This is something else. So based on that, the current gold standard in clinical practice is elimination diet, where if you really want to figure out what your IBS is, and if you're disciplined enough, you are asked to undergo elimination diet, where you essentially remove almost everything from your diet for 3-week period, and then systematically start adding one thing back at a time. As you can imagine, this is a very lengthy, very involved, and very sort of burdensome process. And most people are not able to reliably follow this process. And there is also no guarantee that this is always going to give you the results, right? Because this is primarily focusing on food. If your IBS is triggered by stress or sleep or something else, then this is not going to give you the answer. And you just spend 60 days doing an elimination diet for nothing, so to speak. Food diaries are sort of a next best alternative, where instead of asking people to just remove everything from the diet and add one thing back at a time, they ask, okay, just keep a diary of everything that you have eaten in the past few days or a week, and let's see what might be the likely causes, right? So this is just speculating, so to speak, based on like most people have IBS reaction to lactose. If you're eating a lot of lactose in your diet, let's just remove that and see if that helps, right? So there's a bit of guesswork going on, and that's perfectly reasonable. That's how medicine works. And technology has tried to help in this place by coming up with food logging applications where people can just log everything they're eating, making it easy for them to figure out what might be the possible culprits here, right? However, this is high effort, right? Particularly attempts at using self-track data have been not so successful when it comes to clinical use, where people just collect all of this data, take the application, go to the doctor and say like, look at this. And the doctor doesn't know what they're looking at. So this is not going to help anyone in diagnosing their IBS. So like I mentioned earlier, trial and error is a common practice where you're just trying to figure out, okay, maybe this is a culprit. Let's see if removing this is improving my symptoms or not. So this is a sort of an ingrained practice, which is part of the clinical workflow too. So we figured out if we can support and enhance this process by making it a systematic process that anyone can follow, we might be able to help people determine the cause for their IBS symptoms in a much more low burden manner. And the key question we are trying to answer is, how do we leverage design and technology to support people in their trigger identification journey? And I talked about burden, right? So if you think of a two-dimensional space where burden is on the y-axis and validity is on the x-axis, you have elimination diet in the top right corner where it's really high burden, but the likelihood of it being helpful is also high. Food diaries are slightly below it. And then you have trial and error in the bottom left corner where it's really low burden, but the validity is also questionable because everyone does it on their own way and there is no guarantee whether they follow the directions. So an ideal solution would be something which is really low on the y-axis and really high on the x-axis, right? So the bottom right corner. And for designing this, we sort of relied on existing medical evidence, right? So we relied on 3 key pieces of information. One, food is the most likely common of IBS, and it's also the most actionable trigger where you tell someone not to eat it, and if they don't do it, then that's the actual intervention, versus telling someone not to be stressed is not going to work out. There's a long process involved there where you need to figure out what's the cause of the stress, can the person have any other behavioral intervention to reduce it, and so on. So this was at least a first good place for us to try our approach. And most people experience their symptoms within a 3-hour window of consuming the trigger food. This is true for roughly like 70 or 80% of people with IBS. There's also IBS-C where the onset period is much longer. So we are not focusing on that initially. And then usually people, when they eat a meal, there's usually a natural fasting period where they don't continuously keep eating. So there's a brief 2 or 3 hour window after they have a big meal where they won't be eating anything else. So that's a good opportunity for you to conduct an experiment where you just try to manipulate the food in that particular meal and then ask them to fast for 3 hours, which shouldn't be anything out of the ordinary, and then figure out what the output is. So using this information, we built sort of a N of 1 approach. N of 1 is sort of the statistical experimental speak, where instead of having a large population to run a A/B trial, or so to speak, or a randomized control trial, you're just running an experiment with a single participant, and the participant is their own control and treatment group, right? So you only test for one food at a time. So for example, caffeine or lactose, and you're restricting the entire experiment to a single meal. So you ask the person to eat or avoid a particular trigger food in the breakfast and then fast for 3 hours. And that's their entire experiment for the day. And because people usually have a bowel movement once a day, that's a sort of a natural 24-hour reset period for the entire duration, which allows us to assume that each day is an independent variable, right? So in a 12-day randomized experiment, you can have 6 days where you avoided a particular trigger food and 6 days where you consumed the trigger food. So that's a reasonable experiment design that you can form here. So based on this experimental design, we created an application which helps a person set up their experiment, run the experiment and collect the data, and then analyze the experiment at the end of it, right? It was built using web frameworks from the past decade. But I primarily want to show you and walk you through the design process. This process roughly took a year for us, where you start off with the initial design expertise and medical expertise. When the medical collaborator approached us, they were like, I want you to build an app where I can ask people 150 questions about what they do, what they eat, everything. And based on that, I'll figure out what their likely triggers are. We were like, that's a long-winded approach. What do you actually want to do? You want to figure out whether a particular food is a trigger or not, right? So that's how we negotiated with the medical collaborator and came to an approach for testing a particular food rather than figuring out what their entire diet is. Then based on that, we ran a survey with 60 participants to just get a sense of food-based triggers for IBS. We designed some initial mockups, created some low fidelity prototypes, used that prototype to conduct focus groups with actual IBS patients to see if this process is even something that makes sense to them or is useful for them potentially. We built the application, we did experience prototyping. So this is where members of the research team actually use the process and conduct experiments on themselves. Like if us as non-IBS people, people with no IBS are not able to conduct experiments, then we cannot reasonably expect people with IBS to actually follow through, right? So that's sort of the basic litmus test. Can you do the thing yourself before asking someone else to do the tracking? And then finally, we worked with a nutritionist to come up with certain meal plans or meal options for people who might need that. So like the meal plan would essentially be on the days on which you're avoiding your trigger, what should your breakfast look like? And on the days on which you're supposed to consume your trigger, what should your breakfast look like? Ideally focusing on just manipulating one food item and keeping everything else constant. And based on this entire process of designing the application, testing internally and everything, we conducted a study where we recruited 15 patients with IBS and asked them to schedule and undergo and analyze one 12-day experiment for determining the triggers for the IBS. And just to highlight, the key requirements for this platform were: how do you lower the data collection burden? How do you increase the validity of the collected data? And how do you provide results that are actionable? So if you recall the two-dimensional graph of burden and validity, we want something which is on the lower right side of that. So briefly walking you through the application itself, the first step is designing the experiment, right? So the app is designed to lower the burden by defining minimal tracking needs. So for dependent variables, we already list what are the 7 most common symptoms that people with IBS experience. And for independent variable, we are only listing the 4 most common food-based triggers right now. And this is, again, a feasibility study. This is not meant to be exhaustive. Then improving the robustness of the experiment through design, right? So we ask people to select a start date in such a manner where they are not conducting an experiment where it's sort of a non-typical time period for them, right? So they don't want to do an experiment when they're traveling, when they have a deadline, or for people who menstruate during the menstrual cycles, because these are all things which can be confounding factors for the experiment. The application also provides support for reminders, and we restrict the experiment to the breakfast period only, and we ask people to eat a consistent breakfast for 12 days, and also providing them with some options. Like if you see on the rightmost screenshot, the person is designing an experiment to see the effect of lactose on their symptoms. And it's just giving it some examples of on the days on which the person is supposed to consume lactose, what they should do, and on the days on which they are supposed to avoid lactose, what they should do. And we also provide some structure and support in the data collection process itself, right? So once the experiment is scheduled, you get a calendar view of the experiment where you basically get color-coded days on which you're supposed to avoid or consume the trigger food. And on a day-to-day basis, you have to do three things. One is report whether you complied with the condition, yes, no question. Report whether you fasted after the condition was for the breakfast, so another yes, no question. And at the end of the 3-hour period, report your symptom levels on a 7-point scale. So like the person is not doing a lot of tracking, so to speak, right? It's not like what did you eat, what are you feeling, what everything else. It's literally 2 yes, no questions and 1 like response. And they do this process for 12 days, and that's the entire experiment. And when the experiment is conducted, we provide some actionable results to enable informed decision making. So we do this in 2 different ways. One is we provide textual interpretation of the results. So based on the trial, there is strong evidence that your frequent bowel movements get worse when you consume lactose. This is the confidence. And we also provide a sort of custom visualization we ended up making for this, where you have a timeline view. Timeline view in N of 1 studies are usually better when you're doing a phase-based design. So you have 6 control days and 6 treatment days, right? Because we are doing randomized design, timeline doesn't provide that much of a value. There is still value in terms of like, okay, I might have had some deadline which I didn't plan for, and that's why the symptoms spike. But beyond that, it's limited value. So to counter that, we came up with a sort of a dot base violin plot, so to speak, for the lack of a better word, where you're just dividing the days between your control and treatment days and seeing on the severity scale how severe the symptoms were. So we don't tell you whether the difference is meaningful or not. It's up to you to interpret whether the difference that you're seeing here is meaningful for you. Yes, Aditya.
So just for clarification,
Yeah.
so the on the x-axis consumed lactose is basically all the days when they consume lactose, and
Yeah.
then okay, cool, thanks.
Yeah, it's literally taking the 12 data points which were there in the timeline and organizing them based on the severity of the symptom levels. And it's 6 days of consumed lactose and 6 days of avoid lactose.
Right, thanks.
So essentially, you can try to come up with your own average of like average symptom level was close to moderate on days when which you consume lactose, and on days on which you avoided, it was mild. So is the difference between mild and moderate meaningful to you? That's up to you to decide. We are not making that interpretation for you. We are just telling you this is the difference you reported. And this is something we saw in the responses when we asked people to, right? Some people want to see a reasonable difference of 2 or 3 points on the Likert scale, versus some, they're like, as long as there is a difference of 1, that's enough for me to remove this from my diet and have a better quality of life. So for the study, we were essentially investigating the feasibility of people using self-report, right? So this is a new approach. This is not your typical tracking where you just track something and that's it. So we wanted to understand whether people can actually reliably conduct experiments with minimal guidance, so to speak. We conducted an intake interview where we had people come in, we explained what the study was, we set up the application on their phone, help them set up the experiment. If they had any questions, we were there to answer that. After that, the person goes home. Whenever the experiment was scheduled, it would start. They would do it for 12 days. And at the end of the experiment, we asked them to come back in for a exit interview to go over their experience. So it's a typical HCI study, so to speak, right? And we did thematic analysis of the themes extracted from the interview conversations. Here's again a typical shot of qualitative analysis that you have seen many times in HCI studies. There were three key findings that I want to highlight, right? So based on the initial goal of we wanted to reduce burden, we saw that the application was actually able to reduce tracking burden. So as one participant quoted, it definitely took a lot of the strain away of trying to remember all the stuff that you're supposed to be paying attention to because it's all in the app. It also promoted completion. We saw 12 of the 15 participants actually reported 100% compliance for a 12-day period. As one participant said, this held me accountable and it required me to keep track of it, which is always a challenge with trial and error. There's nothing holding me accountable. So I appreciate that this did that. And finally, people also reported getting value out of the experience itself. So as one participant said, I'm glad that they didn't show any evidence because it means I can eat more things. And this is a really fascinating thing that I saw when we were designing the platform, where even if the experiment fails, it's still valuable information for you, right? So there were examples of people who were just removing everything that they suspected might be causing their symptoms just because they didn't want to experience the symptoms. And if the experiment says, like, if that person ran an experiment, is caffeine a trigger for their abdominal pain? And the experiment came back and said, like, it's not. That's vital information for that person, and the person can reintroduce caffeine in their diet without any concerns of like it aggravating the symptoms. So there's value in both positive and negative outcomes of the experiment here. And based on this, we explored the Bayesian graphical model. We are exploring sort of Bayesian graphical models of individual networks to see if we can figure out impact of different foods on IBS symptoms. This work also led to a notion of templates for self-experiments, where instead of requiring each and every person to be proficient enough to create their own experiment, you can almost imagine sort of a list, like here's a curated list of experiments, just pick one and run it. You don't even need to set it up. You, as long as you that's the experiment you want to do, it will just set up everything automatically for you. And then finally, it has contributed to our exploration of goal-directed tracking approaches in chronic condition, where in contrast to most of the typical applications and devices out there, which just assume that a person wants to do something with the device. So take the example of Apple Watch. It does a lot of different things for tracking. It tracks your heart rate, it tracks your steps, it tracks your sleep, whatever it is. And for all of those things, the designer of that thing has to make an assumption of this is what the person wants out of this. We say in chronic conditions where you don't even know what the person's experience is, it is a folly to assume that everyone has the same goal for which they're using this application. So instead, we should allow people to formulate their own goal and customize the applications to be better suited for those. And this work was published at CHI. It received an honorable mention. It was also instrumental in securing a larger NIH R01 grant for building tools to support chronic conditions. And we have received interest from several medical researchers, startups, and VCs to figure out how they can incorporate this approach in their platforms. Any questions on this? Oh, sorry, I see some comment from Joe. Gamification elements could be a good fit for elimination diet. Oh yeah, definitely. There are different ways in which you can also improve or enhance the experience of the things that people are already doing. We are not saying like this is the best approach or this is the only approach. We wanted to try a different approach, which is not well supported by the current sort of tools that are out there. Shefali, yes, go ahead.
Hey, Ravi, quick question. You mentioned at the very beginning that this was a different approach from what the providers had initially thought that they wanted. So I'm just curious if you had gotten any feedback at the end from the providers about their thoughts about how much of a different approach it was, but whether that they felt it was effective.
So so that interaction didn't happen because the provider had been a member of the team from the beginning. So they were always involved throughout the entire design process that I shared. So it wasn't a surprise at the end where like they told us something, they gave us a design brief, and then at the end of the 6 months, we just came back with something else. So it's more of a involved or participated design, so to speak, right? Where they are the experts in the medical domain. They are coming to us with the understanding that they have and what they think the patients need. And then we are applying the human-centered design process. And as you know, it's all about the process for us, right? Where we are just trying to figure out, okay, let's talk to the stakeholders. What do they need? Does it align with what the expert is saying? If not, let's figure out where the two can meet in the middle, and let's see if that's an approach that we are all interested in doing. And I think this is a common theme that you will see in the next project too. But just wanted to check, like, does that answer your question, or did I just answer some completely random question?
No, that answered the question. It was great. I'm interested in hearing kind of what their reaction was to the different take, but it sounded like they were
Yeah.
very partners in the process and were supportive of your direction.
Definitely. Essentially, they were part of a team, right? They were not like an expert that we reach out to once every 2 or 3 months to see how the progress is going on. They were literally involved in the weekly meetings, providing their input and feedback on each and every step. So it's much more interdisciplinary team rather than just consulting with an expert at that point.
That's awesome to hear. Thank you.
Yeah. Any other questions? Yeah, Aditya, go ahead.
We can take this question after the talk as well, but I'm thinking about these large scale studies, like all of us research programs, very expensive, very time consuming.
Yeah.
And when I saw your study, the alternative idea that came to my mind is, like, if this is basically crowdsourced to a lot of people, then we have findings from each individual, or we have data from each individual with cause and effect, let's say.
Yeah.
So have you had discussion with medical professionals or health psychologists on how this kind of approach would change precision medicine, like compared to what is being practiced today?
Yeah, so I personally haven't talked to people about this, but I followed other researchers who are engaged in this. And there are two things I want to highlight there. Where one is, in my research, I mentioned just briefly earlier without emphasizing it. Basically, I'm taking an existing population level understanding and trying to bring it at a personal level, right? Operationalizing that at a personal level. There's also the other side of that loop where you can take a cluster of personal understanding and personal information that, like you mentioned, and figure out how to enhance the existing population level understanding, right? So it's a symbiotic loop that you're forming there, rather than saying like this is stratification of data at two different levels. So that's one. As for people exploring this, Vineet Pandey, he was at Harvard as a postdoc. I think now he's at Utah. He has done the crowdsourcing option of tummy trials in terms of the approach that he has taken, right? So he built, I think, a few different systems. Galileo was one of them. I'm forgetting the other one, where essentially you are actually using sort of templates of experiments where someone has already curated a list of experiments which are hopefully not harmful for anyone to do. And then you can just go out to the place, select an experiment, and the system will automatically send you text messages every day to just make sure like you are following the prompts of the experiment. And that has its own benefit where you don't even need to go through a clinician, so to speak. You can just run it yourself. It's a complementary approaches for sure. And I'm happy to talk to you after the talk about this in more detail if you're interested. But to make sure like we finish on time for everyone else who might need to head out, let's quickly go to the second project. So Beacon with Beacon, I'm trying to introduce a new measure of neurophysiological function in people with chronic liver disease, right? So you can reduce this to mean just cognitive functioning, so to speak. So Beacon is a device for self-measuring critical flicker frequency, CFF. It's a potentially important measure for people with liver failure to diagnose cognitive impairments as their condition worsens. And in this project, we developed a new device, completed an initial validation, and working towards active home deployments. Again, the same outline as tummy trials, where I'll go over the medical background first. So hepatic encephalopathy is a spectrum of neurocognitive impairments caused by liver dysfunction. And like me, if there are others who don't understand how liver causes brain issues, the pathology is because the liver functioning is impaired, toxic buildups, toxins start building up in your bloodstream. And as the concentrations of those toxins increase, they start interfering in certain neural pathways. And when this happens, it starts impacting your cognitive functioning. At earlier stages, it's very mild and difficult to detect, but as the condition worsens, it becomes obvious, and there are even physical manifestations. So ataxia is a test where you just essentially ask a person to just stretch out their arms and put their wrist upright, and it will start flapping. So that's a physical manifestation, which is already a sign that the condition has worsened quite past the initial state. And so timely identification is really vital in this situation. And in terms of the impact or the scope that we're looking at, like roughly 4.5 million adults in US are diagnosed with end-stage liver disease. And this is not just because of alcoholism, right? This can be because of overweight, weight management issues, hepatitis, injury, or something else too. And of those 4.5 million, it's estimated that roughly 80% of the patients with cirrhosis often developed hepatic encephalopathy at one point or another. It can be transient, it can be persistent, it can have different sort of characterizations at that point. And it is often undiagnosed until it has progressed to severe impairments. And frequent screening, although recommended, is seldom administered, as it's the case with most other things in the medical system where everyone is overburdened and understaffed. So it's not going to happen. So unlike other chronic conditions, it's difficult for a person to self-diagnose this, right? Cognitive impairment is not something that you can just say like, oh, okay, I think I'm not, I have cognitive impairments, right? This is something where you need some sort of a third party or an objective measure, whether you're performing normally, so to speak, or performing in a different manner. And the screenings that are happening in clinic happen at best like every 3 to 6 months, which is ample time for the condition to develop and worsen. So the key question that we want to answer in this space is, how do we support people in getting an objective measure of HE at home, and ideally in a non-invasive manner, right? You don't want to put electrodes or ask people to wear EEG caps all the time. So the requirements that we came up for our solution were, it needs to be affordable, it needs to be easy to use, and it needs to be portable enough where people can either keep it at home or move it around if they need to. In terms of what the current tests are, there are a few different ones. So number connection test is one, true color and word test is another. In number connection, you're literally giving a person a sheet of paper with numbers and sometimes even letters and asking them to connect them in order, and you're timing this. So you're trying to see if the person is doing this within the acceptable range, or is this person slower than usual? And there are different variations of this where you're asking them to copy digits, you're asking them to just put dots in the center of circles, or you're asking them to do line tracing. True color and word, I'm guessing people have seen this test, they just might not be familiar with it, where you're essentially, there are two different implementations that I'm familiar with, where you just have symbols of a particular color and you're asking a person to identify the color, or you're using the words for the colors, but you're asking the person to guess the color of the word, not the word itself. And the issue with this test is, as you can imagine, it's kind of like a game where you will expect that the more you play, the better you get at it. And that is the case, right? Where if you ask the person to just use this every day, they will just keep getting better. So it stops serving its utility as a diagnostic tool at that point. So critical flicker frequency is something that has been studied in literature in the past. What it is it's a test of visual perception where you're trying to figure out the minimum frequency at which a flickering light source appears fused to a user, right? So let me give you an example. This is exaggerated because showing a flickering light captured on a camera with a different frame rate on a monitor with a different frame rate. So just play along. So imagine this is a flickering light of 20 hertz where everyone should be able to see it's clearly flickering. You systematically increase the light to be steady to a point where like no one should be able to see that this is flickering. And the point along this line where you can basically see it is flickering, and if you increase it any further, you cannot see it as flickering, is the threshold that you're looking for. And this threshold, it has been shown in research to decrease in people who are experiencing hepatic encephalopathy. And the reason for that is when liver functioning is impaired, there are certain visual pathways in your brain which are also impacted by the same toxins. So that's why you're able to see the effect of liver decline in your vision, or rather, in your vision. And the bigger advantage of this test is it's not dependent on effort, language, or numeracy skills, right? So like the previous test I showed you, you at least need to know how to count to 1 to 20, or how to say the alphabets, or how to read a particular word. None of that is necessary in this test. And it has been shown to have reasonable accuracy of 80% with a sensitivity of 65 and specificity of 91% in clinical trials. However, the big sort of roadblock was devices such as this were necessary, right? You have a big viewing chamber connected to a controller, connected to a proprietary software. It costs like $3,000, which is not a humongous cost for a medical device for a clinic, but still, it's a specialized enough device where no one would go out of the way to have it. It requires dedicated setup space. Again, space is a constraint, and requires specialized training. Again, you have to train either the technician or the nurses on how to use it. So another hassle. And it's all usually not available in most clinics outside of research practice, right? So with this, we built Beacon, which is a tool aimed to make CFF measurement more accessible for patients and clinicians. And just briefly going over the system architecture, it's like a combination of device which looks like a lamp in its current form factor, connected via Bluetooth to a custom smartphone application. And the application is used to generate different light patterns in the device to figure out what the person's threshold is. And this has gone through multiple iterations. And going back to Shefali's earlier comment about the medical collaborators. So the story behind this project is the medical collaborator came to us and said, like, can you just make me a couple copies of this existing big device, because I need to use it for some research. And in making that, we had this realization that we can actually make it much smaller and much more portable and much more user-friendly. So that was definitely not his ask, but he was interested enough to sort of tag along with us. And he has been our collaborator for like the past 5 or 6 years, right, at this point. So definitely not your typical consulting-based expert, but more of a team-based interdisciplinary team member at that. So we had some initial iterative, going back to the design process. So we had some initial iterative prototyping. We did some formative studies, comparative studies to establish it's performing on par with the existing device. Ran a focus group to understand the perspective of different stakeholders, such as the hepatologist. This should be 150. We ran a clinical validation study for multiple years. We collected data from 153 patients. For a subset of those patients, we are also asking them to use the device at home for like 6 weeks. And that's sort of the journey of the project so far. And it's still an active project for me. And just to show you what I mean by iterative prototyping, we started off with literal cardboard prototyping for the device, where like everything was shoved in on the other end, where the electronics and the battery and the LED was there, just to do a proof of concept. Can we actually replicate the measures that the device is giving us? Moved on to a laser cut box. And after that, we had the realization we don't even need the entire box, because the box is serving specific purposes. And if we account for that, we can make it much smaller. So the thing that the box controls for is it controls the viewing angle. So you're ideally looking straight at the light. It controls the intensity of the light. So if you have other sort of lamps or something else, it's not interfering with the test. And it's controlling the ambient light intensity, which is the lamp thing. And it's also reducing any distractions from the background that you might experience. So as long as you account for these 4 factors, you can actually remove the entire thing and just have a separate light. So for controlling the viewing angle, we initially had some guiding LEDs, where only if you're looking straight at the device would you see all 4 light up. Otherwise, all 4 of them won't be lit up, right? So that's how you can ask a person to just manually move their head around and make sure that they are well aligned with it. Then we ran some formative studies with different levels of intensity of ambient light and the light intensity of the light source itself. So we saw that the intensity of the light source has a strong correlation with the measured CFF value. And based on that, we just picked a value which was aligned with the reference device that we had. And we noticed that the impact of the ambient light on the measured value was much less pronounced. So it didn't matter that much, but we picked intensity which was reasonably replicable by anyone. So this would be like a dimly lit room, where you don't need it to be completely dark, but as long as the light is not in front of you or right above you, you're fine. And we ran a comparative study with healthy participants first, because this is unproven technology. So you don't want to directly go to the patients first. So we tested with 41 participants, and we had a good age spread. So we also set up camp in a retirement community. So we had participants ranging between 18 to 99 years of age who use both the devices. And across these 41 participants, we saw a Pearson's correlation of 0.88, which is a very strong correlation for our device. And based on that, we conducted some focus group, like I mentioned, and the key findings from the focus group were everyone would be interested in an inexpensive device that would diagnose HE quickly, but at the same time, they would like to see large-scale quantitative evidence that the test works, right? Because just because something was proven in research in a smaller study that it works, clinicians are not willing to change their practice to account for that, right? They need actual large-scale evidence for that. So to support at least the first stage of that, we ran a clinical validation study. So we said, okay, let's just run like 100, 150 participants through our device and see how it, if we are able to determine whether it's a good measure for hepatic encephalopathy. So based on this, we had 108 patients who had cirrhosis and 108 and 45 participants without cirrhosis. As you can see, if you look at the orange box, the top row is the reference device, Lafayette, and the bottom row is the Beacon, which is our device. Both measures are quite comparable across the two population. And patients with cirrhosis had lower CFF values than patients without cirrhosis. So this was good, at least preliminary evidence. And we also tried different protocols in our device. So force choice was a different protocol that we tried, and we saw that it was consistently giving us like 4 hertz higher CFF values on that. So this was another thing that we discovered, where even the protocol that you're using to administer and determining the threshold has impact on the value that you're noticing. And these are just different graphs showing the same thing, where no cirrhosis versus cirrhosis without prior HE and with prior HE, and there's a reasonable difference between the populations there. And here's sort of the prototyping banner or hero shot, where we just we had a few different things that we wanted to make sure, right? If we want people to use this at home, this cannot be an obviously medical device, because there are certain situations, and depending on the individual, people have stigma with having obviously medical things laying around in their house. So how do you design something which can be used for medical purposes, but also sort of blends in easily in a house? So we are, through different prototyping alternatives, we landed on this current lamp-like design, where it can be easily construed as a weird lamp or just a peculiar lamp on someone's nightstand, and it doesn't raise any eyebrows. In terms of enabling other research engineers, through this project, we were able to establish a new sort of data stream for people to understand and better characterize hepatic encephalopathy. We are currently working on sort of a multi-site trial, and hopefully have a proposal soon for that. Let's see. Okay, we are slightly behind on time. So moving on to the last step. Before that, are there any questions on the second project that I shared? Going once, twice, thrice. Okay, so this is the second half of the talk, where I said I want to have it more of a discussion format, right? So like I mentioned earlier, currently I have a few of the projects that I'm working on with people with Alzheimer's and dementia, which I'm also happy to talk after the talk if anyone is interested. But for the time being, I want to take a step back and think critically about, like, what is the role that we as technologists are playing in the medical system or the healthcare system in this stage in our life, right? So like I mentioned earlier, I'm interested in building tools which sort of leverage new data interactions to provide value. And in this work, I look at data from 2 different perspectives. And I think about health as being data-centric, and I think about health being personal. And how can I go about designing tools which satisfy these 2 constraints, where people are actually able to find meaningful data streams for their health, to answer questions that they might have or take action, and it's personalized to their own needs. So based on that, I want to take a minute to rant about something. And this is essentially a line of thinking that I've had recently, where I think most of the current tools that we are designing are designed with sort of an implicit support for deficit-based view of healthcare, right? So this is essentially identify what is missing, what is abnormal, and determine how to get it back to normal, right? It's being reactive. It's like something has to go bad before we intervene rather than being proactive, so to speak. And I was happy that some of the responses to what does health mean to you question was being like, I don't want to feel like shit, right? That's not you characterizing health. That's in the constructive manner, so to speak. It's about I don't want to feel like shit. That's your characterization of health, and that's a perfectly normal characterization. I have also been in that situation. So the second thing here is the way in which we have gathered evidence in medicine over the past century or two has been around focused on averages. And this is for obvious reasons. It's not necessarily out of malice, so to speak. But I think we are at a time and age where we have the capability and we have the tools and technology to support us to think more at a personal level. So instead of thinking about individuals, we can start thinking about, so instead of thinking about the population, we can start thinking about individuals. So take the example, if a person has high blood pressure, the, sorry. Yeah, basically a person who, when you go in and get your blood pressure measured done, there are usually categories which the person is just looking, the clinician is just looking at, like, are you in a category of normal? Are you in a category of hypertension, borderline hypertension, or whatever it is? They do not account for what's your baseline measure. Like, are you a person who has a typically higher blood pressure on general, and that's just your normal state, right? That's not accounted for anywhere in this situation. So those are the kinds of things that I'm thinking about here. And then finally, how, when we think about and start thinking about these things, how does it affect how we design tools, and how does it affect what kind of sources of data do we turn, right? If you want to think in terms of a asset-based healthcare model, what are the sources of data do you use? Do you use the same data sources? Do you go to different data sources? Do you still design the tools in the same manner? Do you come up with different approaches to designing tools, right? So one of the common things that many health tracking tools do these days is they're focused on supporting behavior change, because the assumption is your behavior is not ideal. You want to change it to something ideal, and that's what we want to do. So our focus is less on identifying what the person is doing well and focus more on what the person is not doing well and trying to fix that. So with that said, like, here are a few different opportunities I think exist in the space that I would be interested in exploring in the near future, where how can we design tools to support asset-based model of healthcare, right? So rethinking how we design health tools. How do we define strengths? How do we identify assets? How do we reward people who are already doing good things? Like, should we reward these behaviors, right? So if a person has really good habits in their life, we should at least acknowledge that these habits exist and they are doing well, rather than just saying they're normal, and it's only when they fall off those habits that we're like, you need to do something about your life, right? And then finally, also critically reflecting, like, is there need for technology in this space? Is this something that technology needs to be a thing that needs to be involved in, or is this something that's more behavioral or societal? So with that, I want to leave you all with one sort of takeaway exercise, so to speak, right? I want everyone to just examine your daily routine and identify what at least one good health practice that you follow. Acknowledge it, right? We all do at least something good in our daily routine, which is helping our long-term health. We need to be more mindful about figuring what that is, being appreciative of it, and thinking more, bringing it more to the forefront of our thought process. And bonus, if you can think about how can we design tools to support this sort of asset-based view of health, that's definitely something that I think will be a big thing in the near future. So with that, I think I'm literally at the hour, and I'll stop talking and take any questions that people have. Ignoring individual baselines, almost like you need a QR code that lists your baseline. This is frustrating. Oh, definitely. Like this, I had a recent sort of exchange with a friend of mine who underwent this, where she had a delivery, and her sort of baseline blood pressure is lower than normal. And when during her delivery that went in the normal range, she tried to tell her doctors, this is not normal for me. This is actually high for me. You need to do something. And she just had to go really out of her way. And it was a stressful experience for her to convince anyone to take her seriously at that point. So this is not just sort of like, it's a routine thing for us. It can be a matter of life and death in many situations. And yes, we don't have any current tools which are designed, like our current EHR system is not designed to have custom baselines, so to speak. People might have to go out of their way to have comments like this person has a lower base heart blood pressure. To keep that in mind when you're doing everything else. Peter, did you have a question or comment?
Well, I had a comment.
Yeah.
So one thing I thought was interesting about what you presented is how you minimalize the amount of data.
Yeah.
Right. Because I think that there is a lot of all trend, right, that is towards the big data.
Yeah.
Right. And where the belief is that if we track enough data points, right, about everybody, then we can, out of that mess, we can create some insights, right? And we can do it to your second point, to your point about making it personalized and figure out your baseline, we can figure out the personal baseline, right? That if you, right, if you wear a heart rate monitor for a year, right, or you do anything else, right, we know what the baseline is for each individual, right? But I still thought it was interesting that you, in all your experiments, and all your experiments went towards a notion of less data is better, right? You were asking fewer and simpler questions, and so that you out of that could get value, right? And I'm making it more as an observation as a specific question.
No, that's definitely been the intent for us, where we know from self-tracking and personal informatics literature that the more you ask people to do things, the faster they will burn out and stop doing anything altogether, right? So if you want people to do things and particularly manually collect data for you, you have to keep it as simple as possible. I'm not saying we reached that point. There are definitely easier sort of heavy duty implementations you can do, right? So one example that my colleague explored in his work was, can we actually update the lock screen unlock mechanism in Android phones to be an input, right? So instead of wasting an interaction, unlocking the phone, clicking on the app and going in and reporting something, can you literally just have a pop-up that asks you a question and you can just answer it on the lock screen itself, thereby reducing the interaction modality and also reducing the burden or the threshold of the barriers even still. So there are definitely ways in which we can do this. The counter to this that many people often think is automating data collection reduces or bypasses this, right? That's not often true, because the moment you automate something, you're taking it farther away from a person's field of view or conscious thought process. And it just becomes some background collection process where they have to go out of their way and actually look through the data and make sense of it to get any value out of it. So there are different ways, reasons why we're doing the sort of explicit small data collection, but yes, that has been an intent for us. Yeah, Aditya, go ahead.
So it's slightly tangential, but in your studies, especially around tummy trials, did you come across any comments or concerns around data privacy? Because when it comes to health, there is a lot more concern around that.
So we didn't come across any explicit concerns around privacy as such, because again, it was a prototype and we are essentially evaluating feasibility, and they were working with their own providers at that point. So it's not like the medical data is going anywhere outside of the triad of the participant, the clinician, and the researcher, so to speak. We are worried about privacy, so to speak, where like in Beacon, we are concerned about like what kind of data are we collecting at that point. We right now we are only collecting the CFF measure, which in itself is not medical data, right? We have to do a lot of interpretation on top of it for it to be viable medical data. And so far, we have actively avoided interfacing with EHRs just because we know it's a humongous monster and messy situation where if you're not careful, you're just opening a back door for anyone to just come in and take the data. But in terms of actual sort of project focusing on privacy, I haven't done anything right now so far, but right now I'm actively conversing with a few colleagues in nursing and sort of communication or kinesiology, I think, where we are trying to come up with tools that people can use to evaluate ethical implications of the technology. So it's not privacy, so to speak, but we are trying to figure out if we can generate tools like not every we don't expect everyone to be an expert in ethics, right? So at that point, if you are someone who's designing a health technology tool, what does that mean? You just don't do it? No, you'll still do it. So for those kind of situations, we want to come up with a toolkit where your person can just say like, okay, answer these 5 or 10 questions about your technology to at least get started thinking about what are the different implications or directions that ethics might be come to the forefront of how you deal or how you launch this technology, and see if you are willing, if you're able to change anything. We are not expecting to provide solutions, but at least bringing that to the forefront of people's thought when they're developing technologies is the first step. So I can imagine doing a similar thing for privacy, so to speak, right?
Mm.
So, if you're familiar, let me share this. So there's this resource, which is essentially a deck of cards. It's like a 16 card deck, where one of the things that they're focusing on is essentially surfacing these kind of scenarios. So privacy is definitely one of those scenarios where, say, if you have a data leak, what are the steps that you have, processes that you have in place to deal with that? So building these kind of resources to support designers and researchers better account for and better be prepared for these kind of scenarios is definitely a thing that I'm interested in doing.
Your site looks pretty cool. Thanks for sharing.
Yeah. Yeah, Joe.
Muted,
Yes.
of course. I guess I just had thoughts
Yeah.
to tag on to Peter's comment about like
Mhm.
the philosophy of data collection. And it sounds like to me there's a lot more value in like actual experiments, like targeted experimental data compared
Yeah.
to the just like sucking in data from the world
Yeah.
and hoping there's like a natural experiment in there somewhere. Is
Yeah.
that right?
Yeah, definitely. So like there is a style of self-experimentation which you can call naturalistic experiment, where you're just literally collecting all the data and then doing a post hoc analysis of like, okay, if I were to run this experiment, what would it look like? It's perfectly reasonable. Like if you're particularly the type of person who enjoys collecting a lot of data, that's perfectly reasonable for you. But that shouldn't be the only option for someone who's interested in doing that, right? So when we are designing these kind of things, we want to be much more mindful about exactly what's the minimal viable data that you need, how do you collect it, and how do you provide the maximum value out of that and leave it at that. And it's definitely not a model which will fly in big companies, because that's not something that you can make a lot of money on. So we'll figure that out when we get there. Yeah, Erica. So I'm assuming you're talking about tummy trials, right? So yes, in terms of the broader goal, the expectation was the recruitment criteria was essentially the person needs to be interested in figuring out whether a particular food is a trigger for the symptoms or not. So that way we were ensuring that everyone we were recruiting was at least sharing the same goal with which we designed the application. However, the migraine project, which I didn't talk about, which a colleague of mine is actually the lead on that, and I think there is a new lead on that right now. That application was designed from the ground up to support different goals, and particularly the evolution of goal. So take the example of migraine, right? Where the first time you are diagnosed with migraine, you're like, okay, what is this condition? What do I have? So there's a huge learning curve. You're trying to understand what the condition is. You're trying to understand what might be causing it. There's a lot of learning happening. Once you are past that particular stage, The next stage can be either experimenting or determining what particular triggers are the worst for you. Once you're also gone through that stage, the next stage might be just maintenance, where you're like, I just need to keep track. Like, I think every time this happens, I'm going to have a really bad episode. So I just need to be mindful and keep track of that. Right. So as a person's understanding of their own condition improves and evolves, so does their goal. And the migraine app was designed in a way where as the person progresses through the different stages of the goal and different stages of understanding their condition, the application interface also changes and supports the different things that they need to do for those stages. Yeah, Aditya.
In case others don't have a question, this is fascinating stuff.
Yeah.
Like once again, going back to like tummy trials, do you have a sense of like how sustainable it is in the long term? Like, can people do it consistently for 6 months or more?
So ideally, it's not something that you want to sustain, right? So the way we think about, or at least the way I think about that entire process is, it's one of those things where once you have your answer, you don't need it anymore, right? Once you know what your triggers are, you don't need to continue experimenting on that. The next stage is essentially figuring out how it can be behavior change, or it can be something else where, okay, now that you figured out that these things are your likely triggers and these things are not your likely triggers, what changes in your lifestyle or what changes in your diet do you need to make? And tummy trials has nothing to do with that. So the way we imagined it is essentially it's a smaller part of the larger process of chronic care management, where initially when you are doing the exploration, or when you're doing the when you're first diagnosed, you have a learning curve. You might do just basic self-tracking to collect a lot of different information to see what's happening. Once you have done that stage, then you might have questions. Okay, is this the thing? Is this the thing? So that's the stage when self-experimentation applications would be helpful. Once you have done that stage, you move on to the next stage and you don't look at this. So it's not at all in the intent of the design of the platform for it to be a sustained engagement.
Makes sense.
Any other questions?
I think we are winding down.
Sounds like it. Yeah.
I appreciate all the questions. Sorry it took longer, and I'm thankful for those of you who are still around.
Yeah, thank you again for this talk. Hope you have a wonderful end of semester. And
nice meeting you, at least virtually. Take care.